Estamos aquí para darles la bienvenida en este año académico 2022, la nueva mesa directiva encabezada por un servidor y que en el bienio 2022-2023 hemos preparado una serie de actividades muy atractivas. La idea de esta primera actividad es, después de una pausa, desafortunadamente por la cuestión de la pandemia, poder iniciar estos webinars que estaremos puntualmente organizando cada mes, realizar también nuestro curso anual, el cual presentaremos al final de este webinar con mucho interés y altas expectativas, y agradecer a todos ustedes su puntual asistencia. El día de hoy, para iniciar con el pie derecho, hemos decidido empezar con un área de mucho interés, que es los trastornos esofágicos, y una entidad emergente, que es el efecto que tienen los opioides en el tracto digestivo superior. Para eso me permito presentar al doctor Luis Raúl Valdovinos. Él es nuestro secretario de Relaciones, quien tendrá como primera parte de este webinar presentar a nuestra ponente, la doctora Dianna Snyder, de la Clínica Mayo, quien nos hablará al respecto. Luis, buenas noches, bienvenido.
Hola José María, muchas gracias por la presentación y pues bueno, tengo el honor esta noche de presentar a una buena amiga. Ella la conocí en la Clínica Mayo, su nombre es Dianna, como ya la presentó el doctor José María. Ella es una entusiasta de estudiar los trastornos motores esofágicos relacionados a opioides y tiene varias publicaciones y ha presentado varios trabajos en congresos e inclusive acaba de escribir un artículo muy completo de las interacciones de los medicamentos en el esófago. Por si tienen tiempo de buscar su apellido en PubMed, van a poder encontrar este artículo. Ella estudió medicina en Chicago, después hizo sus fellows de medicina interna, gastroenterología, en la Clínica Mayo, y finalmente ella se quedó un año extra en la Clínica Mayo en Arizona, haciendo un fellow sobre enfermedades esofágicas con el doctor Marcelo Vela. Es un honor para nosotros tener esta noche, Dianna. Welcome, Dianna, y los dejo con Dianna para comenzar.
Hi, thank you so much, Luis and Jose, for having me. I really appreciate it. Buenas noches. So as mentioned tonight, I'll be discussing opioid and cannabis-induced esophageal dysmotility. I have no disclosures. So learning objectives, first I'll start out by discussing what exactly is opioid-induced esophageal dysfunction, including the clinical diagnosis, pathophysiology, as well as management pearls with the data that we have thus far. And then I'll discuss cannabis-induced esophageal dysmotility, including a few small background studies, the recent pilot study that we completed, first looking at this in high-resolution esophageal manometry, and then finally our hypotheses on the pathophysiology in this area. So first to talk about the opioid epidemic, as you'll see here, most of the data I have is from the United States. However, I think a lot of this can be extrapolated to Mexico as well. And so about 11% of adults in the United States suffer from chronic pain, and long-term opioids are prescribed to about 3 to 4% of the population. And more than 160,000 people have died from opioid medication overdoses since the late 90s up until 2014. And a little under 2 million people are either abusing or dependent on prescription opioids based on data from 2013. And so our Centers for Disease Control released a prescribing guideline to help promote safe practices for opioid prescriptions, and this was released in 2016 to try to combat some of these issues. And looking into the data in Mexico, it looked as though historically the impact may have been somewhat less on opioids in Mexico compared to the US. However, more recently, with the aging population in Mexico similar to the US, I think that these opioid disorders will be just as relevant in Mexico as it is in our data in the US. So as we all know, opioid effects in the GI tract have been well elucidated in other organs, including colonic dysfunction, gastroparesis, as well as small bowel dysmotility. It's really in the more recent years that we've investigated these opioid effects on esophageal dysfunction. So first I'll start out with a case. This is a 67-year-old female. She had dysphagia to solids and liquids when we were seeing her in clinic a couple years ago, and she was having this for about 1 year and occurring quite persistently several times per week. She does have a prior medical history of GERD. She had a Nissen fundoplication in 2009. She also has chronic osteoarthritis, and she takes hydrocodone acetaminophen 10-325 about every 6 hours. And so in converting this 1-to-1 to morphine equivalent doses within 24 hours, this would be about 40 milligrams. And this was consistent for about 2 years. In addition, she had opioid-induced constipation, very well controlled with polyethylene glycol, as well as postural orthostatic tachycardia syndrome. So here's her high-resolution manometry study. As you can see, there's normal peristalsis with a DCI of a mean of 1200. However, she had incomplete relaxation at the esophagogastric junction with an elevated IRP that was persistent between supine as well as upright swallows. So we proceeded with upper endoscopy. As you can see here, her esophagus was normal. There was no evidence of a mechanical cause for esophagogastric outflow obstruction, including no peptic stricture or other etiology. As I mentioned, over 10 years ago, she did have the Nissen fundoplication. As you can see in the bottom photo here, it was intact. It didn't show any resistance to passage of the endoscope, and it didn't seem to be overly tight, but rather in the appropriate position. So before I show you her flip topography, I want to remind everyone in the audience about flip topography since everyone has different backgrounds on using this. So this is what the flip topography system looks like. So essentially it's an impedance planimetry system where we're able to measure secondary peristalsis as well as esophagogastric junction distensibility. So essentially it's a bag with a 16 centimeter length that has several impedance planimetry sensors and then a pressure sensor at the distal end. And this is placed transorally during a sedated endoscopy. And then sequentially, we increase the milliliters until we get to a point where we can measure the distensibility of the esophagogastric junction. So we start at the low end at 20, 30, 40, 50, and then get up to 60 where we measure the distensibility. And as you can see here, part of what we measure are the secondary peristaltic contractions. So this looks very similar to high resolution esophageal manometry. However, this is actually measuring diameter rather than pressure, and then secondary peristalsis because it's distension induced rather than primary peristalsis. So this is what we consider a normal pattern of these repetitive antegrade contractions here. So before I show you our patient's flip study, I wanted to show examples of studies. So this is an example of a patient with achalasia. And as you can see, there's no contractions going on. And looking on the right side here at the hourglass, you can see how narrow the waist is there. So the distensibility at the esophagogastric junction is quite low. We measure that as the cross-sectional area over pressure. And so this one's quite low, under 2.9. This one's less than 1. So here's the same patient immediately after a poem. And you can see, obviously, we're not restoring contractility, but we are restoring the distensibility of the esophagogastric junction. So you can see how much wider the waist is here on the hourglass on the right and the improvement that occurred after poem. So now I'll show you our patient's flip study. So here's the example from our patient. As you can see on the left panel, the contraction pattern is not very specific. We're trying to understand more about secondary peristalsis and flip patterns, but it's a non-specific pattern. However, there is some peristalsis there. It's not absent like our achalasia patient I showed you. However, as you can see on the right in the hourglass, there's quite a narrow waist there. So that's low distensibility at the esophagogastric junction. The distensibility index was around 1 for our patient, so definitely low. So what would you do next? Would you do a poem? Would you wean the patient off of opioids? Would you consider a pneumatic dilation, or would you consider a large standard dilation with a bougie or a balloon? So I'll talk about what we ended up doing once I discuss further in terms of opioid dysfunction. So as I mentioned, opioid-induced esophageal dysfunction is really a clinical diagnosis. So it's a combination of symptomatology, chronic opioid use, as well as manometric evidence. So all of these need to be in combination to really make this clinical diagnosis. In terms of the clinical presentation, I have to let you all know these are biased numbers. This is really in the setting of referral bias because these numbers are based on patients that were referred to our esophageal clinics and really do not represent the true prevalence within the full chronic opioid population. And we really need to do further studies to study the entire population to really understand that. But based on the current data we have, the dysphagia rate is the highest at about 60% of this patient population. That's followed by reflux type symptoms in about a quarter of this population. And then finally, a little bit under 10% will have chest pain. So one of the first studies looking at chronic opioid findings on high resolution esophageal manometry was with the Mayo Arizona group in 2015. And at that point, they evaluated 121 patients taking chronic opioids, meaning for at least 3 months, and compared that to patients who were symptomatic, but 100 non-users from opioids. And they found a higher rate in the opioid population for impaired esophagogastric junction relaxation, esophageal spasm, as well as achalasia type 3. And I'll go into this further. So before I talk about all the manometric evidence that we have from our recent studies, this is a nice schematic outlining what we're seeing in OIED. So on the left here, we see our standard swallow where there's contractions that are proximal to the food bolus. And then there's declutative inhibition more distally with relaxation of the body, as well as relaxation of the esophagogastric junction. However, in OIED, we're seeing these high amplitude disordered contractions occurring proximal and distal to the bolus, as well as impairment in the relaxation distally, whether it's high amplitude contractions in the distal body or impaired relaxation of the esophagogastric junction. So this is the critical part to see what the manometric evidence is for opioid-induced esophageal dysfunction. So the 4 main findings are distal esophageal spasm, esophagogastric outflow obstruction, jackhammer esophagus, as well as achalasia type 3. And you can see I've delineated 2 different rows here. So the first is looking at patients that we studied retrospectively who were taking the opioid right up until the manometry study, whereas the lower row is showing patients who had held their opioids for at least 24 hours before the study. So you'll be able to see there is a bit of a difference. So first, if we take distal esophageal spasm, almost up to half of those patients had this finding. However, it dropped to about a third for those that had held it before the procedure. Next, for esophagogastric outflow obstruction, anywhere from 27 to 43%, depending on which study you look at. And this was lower at 7% for those that held it. Jackhammer was a bit lower in total at 12 to 24%. Again, it dropped down to 5% for those patients holding it. And then finally, we do see achalasia type 3. It's the rarest of all 4, but it isn't up to 11%. And again, for patients holding it in that particular group, we didn't see any evidence of achalasia type 3. So overall, if you take our general patients that come with symptoms to our esophageal clinic and receive manometry, about 10% should have any combination of these manometric classifications, whereas in our opioid population, we're seeing about 25% of patients are presenting with symptoms in one of these findings. So it's a lot higher than the general population of what we know thus far. So the next thing we wanted to sort out, well, does it matter which opioid they're taking, and does it matter the dosing? So this was the largest retrospective study to date that we did with 225 patients taking chronic opioids. And indeed, we found the stronger opioids, meaning oxycodone and hydrocodone, had significantly higher rates of opioid-induced esophageal dysfunction compared to those patients taking tramadol. And quite a difference here, 31% and 28% compared to only 12% in the weaker opioid group with tramadol. So once we completed that, then we wanted to sort out, so what does this mean in a standardized metric? So we converted all of the doses over to morphine equivalent 24-hour doses. And with this, we did see a trend towards a dose effect. So those patients that truly had OIED were taking a median about 45 milligrams of morphine in 24 hours, whereas those who did not have evidence of OIED were on the lower side at 30 milligrams within that 24-hour window. As I mentioned, this didn't reach significance, but there was a trend here in that dosing. So then we wanted to elucidate a bit further. What do we understand about the pathophysiology here? What exactly is going on in the mechanism of opioid-induced esophageal dysfunction? So this came up because we noted clinically that during the multiple rapid swallow sequence that we use as a provocative maneuver during our manometry studies, we were seeing incomplete deglutitive inhibition in some of our chronic opioid users. And so to remind everyone, in the update last year on Chicago Classification 4, they basically provided us with a model for how manometry studies should be done, ideally with supine swallows, upright swallows, and then a provocative maneuver with multiple rapid swallows, anywhere from 1 to 3 of those sequences. So on the panel on the left here, you can see a normal multiple rapid swallow sequence study. Just to remind everyone, this is where they're taking 5 rapid swallows. The liquid comes in 1 to 2 milliliter boluses every 2 to 3 seconds, so smaller, faster boluses. And during that period of rapid swallowing, you can see there should be complete deglutitive inhibition. There's no contractility going on here, and the esophagogastric junction is relaxed. In addition, following that, there should be an augmented contraction, which represents esophageal reserve, and that augmented contraction should have a DCI that's greater than the mean DCI of the standard 10 swallows. However, on the panel here on the right, you can see in our chronic opioid population, quite a lot of the patients had this impaired deglutitive inhibition. You can see all of the contractions that are going on during the rapid sequence when they shouldn't be present. So we decided to formally study this, and we were very lucky because Luis provided us with healthy controls from Mexico to compare our patients to. So we were very grateful to have him as a collaborator for this study. And so we evaluated impaired deglutitive inhibition during multiple rapid swallows in chronic opioid users, 72, as well as 100 non-opioid users, and then the 24 asymptomatic healthy controls. And you can see there's quite a significant difference here. So the chronic opioid users, more than half of them had impaired deglutitive inhibition, whereas the non-users only about 14%, and then the healthy controls had normal rapid, multiple rapid swallow sequences with intact deglutitive inhibition here. So this really supported our hypothesis that opioids are interfering and knocking down the inhibitory nitric oxide relaxation pathway, leading to this unopposed excitatory stimulation with acetylcholine, ultimately represented with those manometric findings I showed you with spasm and outflow obstruction and achalasia, et cetera. So that supported our hypothesis. So next, we wanted to do the first study looking at chronic opioids and the effects on flip topography. So as I mentioned earlier, I showed you all flip topography. Just to remind everyone, we're essentially looking at secondary peristalsis as well as the distension at the esophagogastric junction. So to remind everyone on the right here on these panels, so panel A, this is a normal study with those repetitive antegrade contractions. And then on the hourglass on the right, you can see how wide the waist is with normal distensibility at the junction. And contrast that to panel B with these abnormal retrograde contractions. And then on the hourglass, a narrow waist, incomplete or impaired distensibility at the esophagogastric junction. And then finally on panel C, another example of achalasia with no secondary peristalsis and then impaired relaxation. So we wanted to study chronic opioid users in this setting because we hypothesized that maybe in the future, if we understand this further, that we can use FLIP as a screening tool for OIED. So this was a pilot study that we presented last year at DDW. We had 17 chronic opioid users as well as 20 control patients. And these control patients are symptomatic. They're not asymptomatic. So they came for other reasons. And so that'll tie into the data here. There was no difference in our baseline demographics, including BMI, age, and sex. And as you can see here, there was a significant increase in those repetitive retrograde contractions in the chronic opioid users at 29%, whereas none in the controls. However, in the lower panels, you can see that the mean distensibility index and categorically defining distensibility as abnormal or not, meaning is it above or below 2.9, was not significantly different. And I really think that ties into the patient population that we had for the controls. They have other disorders that could produce lower distensibility independent of opioids. However, what was really important that we did take away from this pilot study was actually we looked at the mean 24-hour morphine equivalent doses for the patients that had abnormal distensibility versus normal. And what was really interesting is those with the abnormal DI had a significantly higher dose of morphine per day, so 50 milligrams versus 35. So we were seeing a dose effect here, and currently we are evaluating more patients at all 3 Mayo Clinic sites to expand this study and increase power so that we can understand this further. So back to our patient case. So what we ended up doing initially is actually dilating the fundoplication. As I mentioned, it looked intact, but we figured we would do that before we would start blaming this on opioids. So dilating the fundoplication had no effect on her symptomatology. So we ended up sending her to our pain medicine experts, and they were actually able to help her outpatient wean down her hydrocodone to about half the dosing she was on. So now she was on 5 every 6 hours. And so this turned into a 24-hour morphine equivalent dose of 20 rather than 40. And she had improvement in her dysphagia after completing that. So take-home points for our opioid-induced esophageal dysfunction patients. It's a frequent condition that we're seeing for our patients referred for esophageal symptoms for high-resolution manometry. The main findings that we need to remember are esophagogastric junction outflow obstruction, achalasia type 3, distal esophageal spasm, and jackhammer esophagus. And we do see that there is a trend towards a dose-dependent effect. We definitely significantly saw that stronger opioids are more likely to cause this, but we also saw a trend towards higher morphine equivalent doses causing this as well. In addition, we believe the mechanism is that opioids interfere with those nitric oxide pathway inhibitory signals within the esophagus. So what practical guidance can we give our patients at this point based on the retrospective data that we have? Of course, we need more prospective data to further understand this, but right now, what we can really tell our patients currently is first just simply educating them as a start. Most of our patients are fairly well educated on opioid-induced constipation, are very aware of that, but most of them don't understand that they could have dysphagia or reflux symptoms or atypical chest pain if they're taking chronic opioids. The second step is really to wean the opioids if able, and trying to utilize our pain medicine specialists is the best way to do this. In addition, we believe dose reduction may help, as well as weaning to a weaker opioid such as tramadol, as I mentioned. And then the other critical point becomes, well, what do we do about high resolution manometry testing? So at this point, we believe that patients who are taking chronic opioids who are not able to wean off should actually do the manometry study on the medication so you can see what the pathophysiology is. However, we do also have patients who have acute courses of opioids post-operatively or for whatever reason. And for them, it really makes more sense to defer and watch their symptoms and see if they eventually, when they come off the medicine, if symptoms improve, and really defer the manometry if they're off medications and still have symptomatology at that point. So now I'm going to shift gears and talk about cannabis-induced esophageal dysmotility. This is something we're more recently studying at Mayo, and really has even less data than opioids, but I'll talk about the initial data that we have thus far and some of our hypotheses. So there were background studies that were done in the early 2000s. One of the initial ones was actually a basic science study in dogs, where they actually studied cannabinoid receptor agonists, and they found, interestingly, that these inhibit transient lower esophageal sphincter relaxations. So follow-up studies were done in Europe. One of the important ones was in 2009, and these were smaller studies in 18 healthy volunteers where they were actually given tetrahydrocannabinol or THC, and this also showed that there was inhibition of the TLESRs. So we hypothesized that if cannabinoid receptor agonists are decreasing these TLESRs, then maybe cannabis is interfering with the esophageal inhibitory signals and could lead to motility disorders similar to opioid dysfunction. So that led us into studying this further. So again, our studies for cannabis, of course, are retrospective. We're not giving cannabis to patients like they were in Europe. But so what we did was the initial pilot study. So this is the first study to date that's been done looking at cannabis within patients who received high resolution esophageal manometry. So we initially had screened about 100 patients and then ultimately excluded patients, particularly those with opioids were important to exclude so that we're not confusing the outcomes. And so ultimately we ended up with 27 cannabis users and then compared to 48 non-cannabis users. Because this was such a small pilot study, we categorized our outcomes into disorders of impaired inhibition and impaired contractility. So disorders of impaired inhibition were things like distal esophageal spasm, hypercontractile esophagus, achalasia, outflow obstruction, whereas impaired contractility were ineffective motility, fragmented peristalsis, those types of classifications. So we actually found that there was a significant increase in the impaired inhibition disorders in the cannabis users. So we found they had achalasia type 2 as well as esophagogastric outflow obstruction. So we wanted to look into this further. And so we did a follow-up study trying to sort out the mechanism here and see if it's similar to opioids. So these are the demographic data for this slightly larger study that we just completed. This isn't published, it's submitted to DDW and pending. So here you can see the characteristics. So we have our cannabis users here on the left, non-cannabis on the right. We had more patients to review, up to 36 with cannabis for this study. The mean age was in the 50s. About half the cannabis users were men. And as you can see, there are all different types of formulations, including smoking and edible, smoking being the most common. And one of the challenges here, it's very difficult to quantify how much they're actually taking. What we did quantify, though, is how recent was their use. So at the bottom here, you can see we divided use between within 7 days and greater than 7 days. And about 60% of the patients had taken it within 7 days. So here on the data, I'll show you what that means. So we again wanted to look at impairment in deglutive inhibition during the multiple rapid swallow sequence, so modeled this similar to our opioid study. So on the left here, you can see we have the recent cannabis users within 7 days, and actually 41% of them had impaired deglutive inhibition, which was quite significant, whereas the non-users, only about 15%. So that was a significant difference. So again, we're hypothesizing similarly with the cannabinoid agonist that there is some kind of reduction in the inhibitory nitric oxide pathway. So summary on our data thus far with cannabis. As I mentioned, there are early animal and healthy volunteer studies with conventional manometry suggesting that cannabis reduces TLESRs. And we recently completed the first high-resolution esophageal manometry study showing the association between cannabis and possibly achalasia 2 and outflow obstruction. And again, we think the pathophysiology may be related to basically blocking that inhibitory pathway and impaired deglutive inhibition. So finally, take-home summary points. As I mentioned, OIED is frequent in chronic opioid users, and we really need to be aware of this in our patients with esophageal symptoms coming for high-resolution manometry. And these are the findings that we should look out for: outflow obstruction, achalasia type 3, spasm, and jackhammer esophagus. And really, we should consider this particular in those taking the stronger opioids or higher doses. And finally, we believe cannabis is interfering with inhibitory signals in the esophagus. Further study is really needed to define this. So we're currently evaluating more of our patients to increase the power in our studies and look into this further. So thank you so much. I really appreciate Louise and Jose for inviting me to speak. I'm happy for us to go into any discussion and take any questions at this time.
Muy bien. estamos listos para las preguntas y respuestas. Si nos puedes poner a los tres, por favor. Pues muchas gracias a Diana. La verdad es que es un tema sumamente interesante, de actualidad, y nos ha compartido muchas estrategias en el diagnóstico y cómo tratarlas. Por los motivos del idioma, haré primero la pregunta en español y luego en inglés para poder tener así la respuesta. First of all, Diana, many thanks for sharing with us all this new knowledge about these new entities, about opioids, cannabis, and the effect on the foregut. So there are some questions from the audience. Basically, one of the questions is, how reversible is this condition? You showed that at something between 24 to 48 hours, most of these patients with spasm and jackhammer, they can reverse. But the specific question is, what's the percentage of patients that remains with this condition even they withdraw from opioids?
Excellent question. So the short answer to that is we don't know yet. However, we are studying this further. So just as they had mentioned, I showed our retrospective data that when patients hold the opioid for more than 24 hours, there is some reduction in the manometric evidence and symptomatology. However, we really need to evaluate this prospectively. So that's the next thing that we're doing to really try to figure out the timeline of, one, if we're holding it, how long does it take to get reversibility in symptomatology and manometric findings? But also what percentage of the general chronic opioid patient that has OIED is actually going to improve with that. So, so more to come on that as we do the prospective studies.
Okay, Diana.
Thanks.
I have a question. Maybe this question is related with the previous, but how long you before doing a motility test, you discontinue the opioids if you can?
So right now we're just doing at least 24 hours based on our reversibility and the retrospective data, but it may need to be longer than that. And that's what we don't know yet, but currently at least 24 hours. However, for chronic opioid users that aren't going to be able to wean off and they're going to be stuck on the medication long term, it's okay to do the study on the medication.
Okay, thank you.
Haciendo un breve resumen de estas dos preguntas para la audiencia, el mensaje es que si bien se documenta que hay un porcentaje importante de pacientes que pueden revertir el efecto de los opioides sobre el tracto digestivo superior, no se sabe con precisión cuál es el porcentaje de pacientes que puede permanecer. En ese sentido, hacer un estudio de manometría esofágica en un paciente que consume opioides, lo ideal sería suspender el medicamento 24 horas, pero si no es posible, por lo menos documentarlo. I have another question, and it is something that I think I read some abstracts in the past DDW about other opioids that maybe here in Mexico is not so common for chronic pain, but what happened with codeine, for example? Is there any effect from these medications that people usually take for chronic cough? Is there anything that codeine, even is a low dose of opioid, may induce some of these conditions? Do you know anything about it, Diana?
Yeah, so we haven't studied codeine, and mainly the reason why we were studying oxycodone, hydrocodone, tramadol is because we had a large population on those, and so we didn't have high enough numbers in codeine. But I have seen some evidence from other group studies that codeine may impair relaxation at the esophagogastric junction.
Luis?
Okay. Hi, Diana. Well, I have the next question. Have you been using peripheral acting mu-opioid receptor to treat this condition?
So there are some earlier studies, some of the early conventional manometry studies that were done several years ago. they had basically given healthy volunteers IV morphine, and then they gave them an infusion of naloxone to counteract it. And they did find the reduced relaxation at the junction can be reversed in that manner. But that's really all we know thus far. So we haven't studied that yet. That's another thing that we'd like to do in the future, where we can actually give patients naloxone or other mu opioid receptor antagonists and see if those effects that we're able to reverse in the colon can also happen in the esophagus. So there is suggestion of that from those early conventional manometry studies, but more needs to be looked into on that.
Hay una pregunta hecha por el doctor Miguel Ángel Valdovinos acerca de la fisiopatología y es cuál, o si se conoce cuál es el componente que tiene mayor efecto sobre la motilidad, si es el THC o el CBD. Dianna, Professor Miguel Valdovinos, he's asking you that do you know in the pathophysiology of cannabinoids induced esophageal dysmotility, which component has or plays a major role in this dysmotility? Is THC or CBD, or it's the same?
So it's THC. So THC works on CBD1 and 2 receptors, but it's primarily efficacious on CBD1, and that's the one that works in the central nervous system. So it's the THC. And actually, some of the studies that they did in Europe, where they gave either 10 milligrams or 20 milligrams of THC to the dogs, they saw a dose effect as well. So a higher dose was more likely to reduce the transient lower esophageal sphincter relaxations. They tried to parallel the same study in humans, but had to abort it because when they gave the humans the 20 milligram high dose of THC, they were all vomiting and sick because they were THC naive. So they weren't able to complete the study fully, but at 10 milligrams, they did see a difference.
So, according to this response, there is another question that do you think that is there any potential use of cannabinoids for treatment of GERD, considering that it has an effect on TLSRs?
I like that question because I was actually joking with some of my colleagues about that. I was like, we shouldn't advertise that too much or our patients are going to come to us asking for marijuana for their reflux treatment in our esophageal clinic. So I like that question. Yeah. So technically, so the reason this came up actually and why they had studied that was because there's similar structure in the G protein receptors of cannabinoid receptors to the GABA receptors. So the European studies, they were looking at, oh, well, we use baclofen to stimulate the GABA receptor and reduce TLESRs and refractory reflux. So maybe marijuana does a similar thing with a similar type G protein receptor with cannabinoid. So it's funny that, so I think they were thinking about that pathophysiology as well when that study came up. But yes, at this point, I'm not advocating my reflux patients take THC.
Okay. Hey, we have a lot of questions, Dianna. This is a hot topic. But our professor, Dr. Cosadame, his question about people who consume both cannabinoids and opioids. Do you have some data this kind of patient have more symptoms?
Excellent question. I don't know yet, but I wonder if there would be a synergistic effect. So as I mentioned, for the cannabis studies we did, we excluded the patients on chronic opioids because we wanted to have a clean study where we could really see what the cannabis was doing. So that is a very interesting question. I wonder if they would compound each other, but we don't know at this point.
Haciendo un resumen de esta sesión de preguntas, la pregunta específica del efecto, cuál es el componente, parece que es el THC, y que, bueno, este efecto de inhibir las relajaciones transitorias potencialmente pudiera ser una terapia en algunos pacientes con reflujo, sin embargo, pues la evidencia no la conocemos. Hay un par de preguntas más desde el punto de vista de tratamiento. Una de ellas se hace acerca del efecto o cuál es la recomendación nutricional o el tipo de dieta para estos pacientes y el efecto de la cardiomiotomía. There are a couple of questions about how to treat patients from the point of view of diet. Is there any suggestion or recommendation for those patients that need to keep with this chronic opioid use for chronic pain? Is there anything that you advice for these patients? And the other question is there any role of myotomy, of Heller myotomy, for those patients?
So excellent question. So the first one, there aren't any specific recommendations for this other than the typical lifestyle modifications we'd recommend for anyone with dysphagia: sitting up, aspiration precautions, small bites, etc. But really that's just putting a Band-Aid on the issue, since they really need to wean down if they can, or at least, wean off or dose reduce to try to reduce the symptomatology. However, the other question is very interesting on durable therapy. So there are certain circumstances where patients may need durable therapy, for instance, with a myotomy. However, we have to be very precautious on that, because we do have some data from a few years ago where they looked at patients who had idiopathic achalasia type 3 versus patients that had opioid-induced achalasia type 3. And the patients that had opioid-induced had much lower response rates to POEM than those that had idiopathic. So if we do have to progress to durable therapy because we can't wean opioids for a patient, then we really need to educate them that their response rates may not be as good as the typical achalasia patient.
Thank you. Luis?
I have another question. Maybe you tell us in the presentation, but Dr. Escudero says that there is a relation between the dose and the dysfunction, and relation between the kind of opioid and the dysfunction.
So, sorry, I'm not sure I understood the question.
Okay. Dr. Octavio Gomez question if there is a relation between the dose of opioid and the dysfunction of the esophagus.
Yeah, so we don't know. So basically, when I'm saying that we have patients who are taking the stronger opioids or higher doses and have dysfunction, I'm talking about the frequency, meaning they're more likely to have dysphagia symptomatology and the manometric findings. But in terms of the findings themselves, they're not really subclassified. It's just more likely that they'll have them.
Oh, okay. There also a question about how often there is an overlap between opioid-induced constipation and esophageal dysmotility, and maybe small bowel dysmotility. So how prevalent this is in these chronic users of opioids?
Yeah, excellent question. I've actually discussed this with some colleagues previously. So we don't know yet what the overlap is because we haven't studied it. At this point, opioid-induced constipation obviously is quite common, probably even more common than opioid-induced esophageal dysmotility. But in terms of individual patients and who has multiple levels of dysmotility related to opioids, we haven't studied that yet. I haven't seen any data from other groups studying that yet either, but that would be an interesting overlap to know about in the future.
Un poco la pregunta era acerca de qué tan frecuente es la coexistencia de dismotilidad esofágica, de intestino delgado y de opioides que induce, y constipación inducida por opioides. No hay datos al respecto, pero aparentemente es un área que debe de estudiarse y que habrá un porcentaje importante de pacientes. Hay una pregunta muy práctica, clínica para los que hacemos manometría, donde ¿qué tanto puede esto explicar los síntomas? La correlación del trastorno manométrico, ¿con qué frecuencia se relaciona con disfagia o con dolor torácico? Muchos de estos diagnósticos son manométricos, pero a veces son hallazgos incidentales. So this is a question about a clinical practice for people that is performing manometry tests routinely. Which is the percentage and the correlation between the manometry pattern that suggests opioid-induced esophageal dysfunction and symptoms? Because many times we saw this pattern, we classify as opioid-induced dysfunction, but there is no symptoms there. So there is no dysphagia, there is no chest pain. So it is also happens in normal studies when we run this in some healthy volunteers. So the question is, which symptoms do you correlate more with this esophageal dysfunction obtained in the manometry lab?
Mm-hmm. So as I mentioned, most common is dysphagia. However, again, our patient population we're studying has some referral bias, right? So these are patients who are symptomatic coming to esophageal clinic. So if you take all patients on chronic opioids, including those who are asymptomatic, we don't know what the prevalence of those manometric findings is. So clearly this person has seen that anecdotally and through their work. So one of our goals in our prospective study that we're working on now in evaluating this further is to be able to do manometry on the symptomatic chronic opioid users, but also the asymptomatic, so that we can figure out what the true prevalence is. And then when we wean the symptomatic patients off opioids, see if there's reversibility. So at this point, we don't know what the prevalence is in terms of these findings in those who are asymptomatic.
Thank you. Luis?
I don't have any questions.
So there are a couple of questions here. One of them is because some of these patients are taking opioids because chronic pain induced by cancer, by malignant tumors. There is a question of, is there any clue to try to distinguish opioid-induced esophageal dysfunction from paraneoplastic dysmotility disorders like achalasia, for example? I think it's a tough question, but you that are seeing a lot of these patients, do you have any comment about it, Dianna?
So I would do the standard workup that I normally would do to figure out if there's a secondary cause of achalasia. So we do endoscopy, sometimes with endoscopic ultrasound or CT chest imaging, to see if there's another side malignancy or something that could be causing this. So if we saw that, it would be very difficult to know, is this secondary achalasia versus opioid induced, with the caveat that if it's type 1 or type 2 achalasia, it's very unlikely to be opioid induced, because we really have only seen the association with achalasia type 3. So if you do see 3, it's more likely related to opioids.
Oh, okay.
I have another one. There is a role in the use of PPIs in the treatment of opioid-related dysfunction?
At this point, no. Certainly, as I mentioned, some of these patients can present with reflux symptoms, so giving them a proton pump inhibitor may help symptomatology, but it's not really going to affect the underlying pathophysiology.
And also, there is a question about how often could be esophageal dysfunction in patients with hyperemesis from cannabinoids and cyclic vomiting syndrome. Do you have any clue? Because all these conditions, the people ask too much because coexist, because the factor that triggers the symptoms is the same. It's cannabinoid or THC or CBD or any other opioid.
Yeah, that's an excellent question. At this point, I don't know, because the cannabis studies that we did, as I showed you, were small with 20, 30 patients, and we didn't tabulate if any of them had hyperemesis. But again, the common thing that's coming up is it would be really important for us to study what is the overlap between various organ systems in the GI tract and opioid dysfunction. So that's something we should look into.
Thanks. Please, last question.
I don't have it now. Do you have another one?
There is another in the chat.
I can see.
So,
okay.
So there is a question about your experience in all these chronic opioid-induced. Which other manometric diagnosis do you find? Do you find a high prevalence of ineffective motility disorder? That this is one of the most common disorders that we associate with GERD, for example? Or
we haven't seen an association with ineffective esophageal motility. Part of that is really, as we know, the general population that comes from manometry studies, that's such a common classification, but we haven't seen an association specifically with opioids.
Okay, so thank you very much. Luis?
Thank you very much, Dianna, for this great talk about opioids maybe here in Mexico, we don't have a lot of people using the kind of opioid that in the States use, but we have a lot of patients taking tramadol and tapentadol. And you say that these opioids have the same effect in the esophageal motility, and we need to take care about this new syndrome in the esophageal about opioids. Thank you very much for. Thank you very much, Dianna.
Thank you so much. I appreciate you having me.
For us, as part of the Mexican Neurogastroenterology and Motility Society, it's a pleasure to have a young racing star in the esophageal field. I think that as this condition is new, there is a lot of younger people working on that, and I'm pretty sure that we will see a lot of new publications in the next future. And as Luis mentioned, maybe we don't have this opioid crisis here, but as our population is getting older, I think cancer and chronic pain will be one of the most important problems that will be referred to us. So we really appreciate your talk, and well, you are more than welcome to be with us in a future near without the pandemic. Thanks so much.
Thank you. I really appreciate it.
Pues agradecer a toda la audiencia en este momento. Creo que como una primera actividad fue bastante útil tener y retomar este tipo de webinars. El ejercicio de las preguntas y respuestas ha sido muy, muy satisfactorio. Agradecemos todas sus preguntas, más de 100 participantes en un miércoles a mitad de enero, pues nos deja bastante satisfechos. Antes de terminar, quisiera yo compartir con todos ustedes esto que a partir del día de mañana van a ver en nuestra página de internet. Ustedes van a ver a partir de el día de mañana, si se meten a nuestra página motilidad.org, en la sección de cursos, verán el anuncio oficial de nuestro curso Neurogastro 2022, el segundo curso internacional de posgrado, a celebrarse, esperemos, 4 y 5 de marzo en el auditorio del Hospital Español. Serán 2 días de gran aprendizaje con módulos de contenido actualizado, 21 profesores panelistas, tenemos ya el aval por parte del Consejo Mexicano de Gastroenterología, 15 puntos de recertificación. Podrán consultar ya allí el programa completo, donde, bueno, junto con el doctor Miguel Ángel Valdovinos, el presidente fundador de esta asociación, el doctor Coyo, un servidor, tenemos a bien presentar a nuestros profesores internacionales. Como verán, tenemos un grupo de speakers de lujo, el doctor Pandolfino, Marcelo Vega, Baja Moshire, Lori Kiefer y Marc Pimentel, que junto con nuestra plantilla de profesores nacionales esperemos tener un curso de actualización Neurogastro 2022. Pronto recibirán la invitación formal. Para todos nuestros asociados, recuerden que esta es una actividad gratuita, y a los que no están asociados, invitarlos a que visiten nuestras páginas, se conecten a nuestras actividades y formen parte de la Asociación Mexicana de Neurogastroenterología y Motilidad. Agradezco mucho su atención, buenas noches y que tengan un buen resto de semana. Hasta pronto.
Buenas noches.